Okay, so let's get going. My name's Sophie West. I'm based in Newcastle, but I'm delighted to be here with hopefully a gallery of people you can see, all of whom were involved in this new NICE guideline. And I'm hoping you can also see our title slide. My colleagues have assured me you can. So let's go to slide 1 so I can tell you a little bit more about the day. So all the speakers who will be speaking today were all part of the NICE Clinical Guideline Committee, and we met in London in the main from 2018 to 2021. With COVID, we went online, and you can see us at the bottom doing our final meetings online. So a really enjoyable process, and I'd recommend being involved with the NICE guideline to anyone, but you know, it was a lovely group and we worked well together. And this is the opportunity to share the NICE guideline, which was published in August 2021. But clearly there's an onus on all of us who work within sleep medicine and work with patients with sleep apnea, COPD, obesity, to disseminate and implement these changes, these recommendations within our services. And today just represents the first opportunity to discuss those and perhaps discuss how those dissemination processes might take place and how we might make changes. All the slides we're using, or most of the slides we're using, are taken directly from the guidelines. Some of the speakers have added some extra images of their own. So if you want to reference anything, the guidelines are obviously available on the NICE website, easily accessible online. We're going to have 4 sessions of around an hour each, and going to be trying quite strictly to keep to time to get it all in. We're obviously not all in one big lecture theatre, but we want to have it as interactive as possible. Please put questions in the question and answer box, and then we've got time for discussion at the end of each session. And we'll have some live answers as we go, but it's really that discussion forum where we'll all appear on screen, which will hopefully be very useful for people. For those who want it, there are 4 hours of CPD via the Royal College website. So this is the first session. Myself and Anita Simons, who is our clinical guideline lead, are going to be doing most of this session. But you can see we're going to be having an introduction to the guideline and then talking about who should be being referred into sleep services, should referrals be urgent, who should sleep clinics prioritise and how might they do this, and then a bit on the best sleep study, which Anita is going to discuss. So without further ado, I'm going to hand over to Anita for the first session.
Thank you very much, Sophie, and good morning, everyone. I'm really grateful to you, Sophie, and Annabelle, and Jill, and Chris, and everyone at the OSA Alliance for setting up this meeting. As Sophie says, my job is just to give an overview and run through the scope of the guideline. And I think in the first instance, I want to point out how important it is, firstly for patients. We hope it'll be important. It's not only the first guideline in obstructive sleep apnea hypopnea syndrome from NICE. There has been a previous SIGN guideline from the Scottish Intercollegiate Network. And of course, you may well know that there has been a technology appraisal guidance on the use of CPAP. Importantly, this guideline has a far wider remit and in fact replaces that previous technology appraisal, which was way back in 2008. So I think it's important for patients because it covers this area and also includes for the first time obesity hyperventilation syndrome and the overlap between COPD and obstructive sleep apnea hypopnea syndrome, which has not been covered before. And we hope through highlighting evidence-based diagnostic methods and treatments that we will be able to make more equitable the provision of services for patients. Second point is that we believe that this is an important guideline for respiratory medicine. I don't think anyone could deny that sleep medicine is truly multi-specialty. For example, we rely on talking to our neurology colleagues, and consulting them for management of patients with narcolepsy, parasomnias, REM sleep behavior disorder, and intrinsic sleep medicine disorders. We rely on consulting our dental and ENT colleagues for advice on diagnosis and particularly treatment with mandibular advancement splints and upper airway surgery. And we rely on our general medicine and cardiology, diabetic colleagues, a referral of a large number of patients. So it's truly multi-specialty. But having said that, it's truly respiratory medicine that carries the burden of the diagnosis and the management of patients with respiratory sleep disorders and increasingly other sleep disorders. And it's respiratory teamwork is the key here, because it's truly multidisciplinary. We could not deliver the service from respiratory medicine without working closely with our respiratory nurse colleagues, our allied health professionals, especially clinical physiologists, clinical psychologists, dietitians, a whole range of professionals that work together to provide the service. So if we just move on. And what I wanted to say, I'll just go back one to the previous paragraph. Just a small caveat that we start. Of course, NICE guidelines are really well known and renowned for delivering evidence-based recommendations, and we're covering here the investigation and management of these disorders. There's one caveat that I would say at the beginning, in that because we have to deal with evidence, randomized controlled trials where possible, that we are tending to look backwards on evidence that has been generated so far. So really new treatments such as tongue-based electrophysiological stimulation are not covered in this guideline because the data on those interventions accumulating. That's one important thing to say. The other is the randomized controlled trials have all categorized individuals on the basis of their apnea, hypopnea index. So that's one absolutely standard way of classification. But there are new ways of understanding obstructive sleep apnea, such as different clusters of symptoms, such as understanding patients on phenotypes, their clinical phenotype, so how their symptoms present, and also the pathophysiological phenotype. So whether the sleep apnea is more due to anatomical reasons, a floppy upper airway, or other problems with respiratory drive or arousal threshold. Those were not classifications used in the randomized controlled trials, and so we haven't used them. And so just with those caveats, I will point out to you, as you can see on the screen, that another vastly important reason that we hope that the guideline is taken notice of is that these are highly prevalent conditions. You will see there that it's thought that about 5% of adults in the UK have undiagnosed obstructive sleep apnea, but that was actually an estimate that was done several years ago. One suspects that the prevalence is far higher. In fact, there are many studies showing really very significantly higher prevalence of obstructive sleep apnea, especially if you include mild obstructive sleep apnea, than some of the previous studies that are cited. Over and above that, for obesity hypoventilation syndrome, which is defined by individuals having a BMI of over 30, that they have a raised CO2 level during the day, so daytime hypoventilation and also sleep disordered breathing. You can see the estimates of up to about 4% of the population, but that too may be an underestimate. And I think we can all expect the prevalence to grow as, unfortunately, the prevalence of obesity grows. And then the third area that we've looked at, this overlap between obstructive sleep apnea and COPD, is estimated to affect about 1% of adults. Having said that, the prevalence studies have really looked in different directions. So they have looked at the prevalence of OSA, HS in COPD populations, and then they've also taken obstructive sleep apnea populations and looked via spirometry at the prevalence of COPD. Probably that doesn't give us an overall clear picture, and we really don't know, for example, the prevalence of obstructive sleep apnea in mild, moderate, and severe COPD. And you'll see as we come towards the end that this is an area where we recommend further research because it's difficult to quantitate the problem. But one really important thing to say is that the combined consequences of obstructive sleep apnea and COPD are likely to have far greater consequences in terms of low oxygen levels and increased symptoms for patients. So if we move on to the next batch, there we go. Another key point of our guideline is on the assessment of patients. It's conventionally thought that people present with obstructive sleep apnea with sleepiness. But in fact, as we point out, and you'll see as we come to the assessment and prioritization sessions, that there can be a far wider range of presenting symptoms in terms of sleep fragmentation, fatigue, tiredness, concentration problems. And so just having a raised Epworth sleepiness score is not a sufficient reason on its own to refer people onwards. So we want to highlight to patients and to teams that one has to look more widely in terms of symptom profile, and they can vary from different groups of individuals and also in males and females. We're going to come on to talking about the way we diagnose these conditions, and this is quite a controversial area which we'll come back to. But we've done a close economic analysis on those studies, and so we'll be presenting our recommendations on that. As I said earlier, what we hope to achieve with the guideline is to make more equitable the provision of diagnostic services, because after all, if you haven't been diagnosed, you're not going to be treated, and to make sure that the treatment provision, which of course includes not only CPAP, but dental devices, mandibular advancement splints, and also in selected individuals, ENT surgery, that is equally and equitably available across the country, because it clearly is not the case at present. It's important, and we need to disseminate this message, in that if individuals with these conditions are not recognized and not treated, then there are significant consequences in terms of a very major impact on quality of life, on daytime functioning, in people doing their jobs during the day, impact on driving, for example, which is clearly highly important, and also untreated obstructive sleep apnea, obesity, hyperventilation, and probably the overlap syndrome can exacerbate other health conditions, so cardiac conditions, diabetic management, a whole range of other conditions. And so very important that it's recognized and treated in a timely and appropriate way. And as you see here, we emphasize the importance of experienced and trained multidisciplinary teams and a close link between primary care and secondary care. And if we move on to the next batch, just to summarize that we do have highly effective treatments. This is one of the most evidence-based areas of respiratory medicine, and our treatments can truly hugely improve quality of life and have significant impacts on patients. And that's not only in obstructive sleep apnea, but across the spectrum into obesity, hyperventilation. And we'll discuss the consequences of treating the obstructive sleep apnea, COPD overlap syndromes too. As I said earlier, we want to make sure that the other treatments, such as oral devices, dental devices, access to bariatric surgery, surgical intervention, ENT surgical intervention, is distributed across the country, and people are equally likely to receive that. And then the final point to make is that you will see, as we come to talking about the follow-up of patients and the assessing of the effectiveness of therapy, that we recommend the use of telemonitoring. This aligns nicely with the GIRFT guidelines, getting it right first time guidelines, and also makes sense in terms of convenience, may help improve adherence to treatment, and also has been particularly helpful during the pandemic to reduce face-to-face consultations. But we stress a balance of consultations are important, and personalized follow-up is highly important too. So if we can go to the next slide. Here, and I'm just going to touch on this before we move on to our next session, you'll see we have several of these flow charts. This is the assessment flow chart, and you can see the purple circles in the middle indicate how you start to approach a patient at the top with obstructive sleep apnea, hypopnea syndrome. A second purple circle is the obesity hyperventilation. The third is for those with the COPD, obstructive sleep apnea overlap. And you will see the first things to do in terms of a clear sleep history, the features that suggest obstructive sleep apnea, the underlying features in that individual that suggest a higher risk of obstructive sleep apnea, and then how to prioritize individuals, so those who should be seen quicker because they're more likely to have more significant problems, and then those how to optimally prioritize those patients. And with that, I'll move back to Sophie because she's going to go into those aspects in much more detail.
Thanks, Anita. So just for our delegates, all 227 of you out there at the moment, we're going to use the Q&A function for any questions. So please do put them in as you go, as you think of them there. I hope you can see the speakers. We've asked the speakers to turn their cameras off when they're not speaking, but to try and have a bit of a human feel, do try and keep a speaker view open. Okay, so moving on then. So when to suspect obstructive sleep apnea, hypopnea syndrome. So this is directly lifted from the guidelines, and you can see guideline reference numbers here for you to look things up. This side is for people who you're questioning about obstructive sleep apnea, hypopnea syndrome in, and who then there will be a higher prevalence of. When you work with NICE, NICE is all about publications, evidence, randomized controlled trials. And as you might expect, there are some areas where there haven't been randomized controlled trials to assess what features people with obstructive sleep apnea have. But at this point, this is where the panel who are selected for clinical expertise across the spectrum of physiology, nurses, doctors, surgeons, orthodontists can put in what their clinical opinion is. And we don't think this is probably a controversial list. What we thought was that 2 or more of the following features are important for referral. And I hasten to add, general practice was involved. We had 2 GPs on the guideline, and they were really crucial in saying how much they see of just one of these conditions, but how seeing 2 or more should prompt referral. We were keen to have representation from perhaps the non-typical symptoms, or non-recognized, should I say, that insomnia can be due to obstructive sleep apnea because of sleep fragmentation, which in some people, particularly women, manifests as insomnia. And women may not present with classic snoring, sleepiness, unrefreshing sleep. It may be a much more subtle history of tiredness and insomnia and poor sleep. The others there, I think, are fairly standard. Do put questions if you've got queries in the question box. Cognitive dysfunction and memory impairment can be quite subtle, but I've noticed for years, spouses might say they're just not quite right. They're not quite the person they used to be. Their memory's not so good. And of course, it's complex as to why that might be, that they are having cognitive problems, but poor sleep could be a factor in that, and that's well recognized in trials. Also, I've noticed we're getting more referrals from the memory clinic saying, could these people have, with memory impairment, could OSA be another factor in that? So moving to the other box, sorry, just going to my photos at the bottom. One of these is a well-known photo of a gentleman who was given this montage at his retirement party from his work colleagues. I think it's fairly easy when people present like that to think about OSA. It's much harder when they present like looking like Carrie Fisher to think about OSA, but it's really just keep your mind open and think of the symptoms in front, in the person in front of you. So moving then to think about the conditions in where there's a higher prevalence of OSA. This largely was evidence-based, looking at prevalence studies. So people who've done research to say there's lots of sleep apnea in these conditions. And of course, some of them are, you know this already. If you have obesity or you're overweight, particularly depending on where your body fat distribution is, in men, if it's in their necks or abdominal obesity, you're much more likely to have OSA. Increasingly, it's recognized, and there's good evidence that obesity in pregnancy and being obese before you become pregnant will make your OSA worse or make OSA develop. But we think pregnant people, OSA isn't necessarily recognized. So this is important to flag this. I think it's well known that hypertension is associated with sleep apnea, particularly treatment-resistant hypertension. And if you're seeing these patients, think about referring them for sleep studies if they've got features of OSA. Type 2 diabetes is now well recognized as having an association. There's good data about cardiac arrhythmias, particularly AF. And certainly in Newcastle, our cardiologists are good at thinking about, do they have OSA when they're seeing them for AF, and particularly before ablation. Stroke and TIA, so a classic cardiovascular risk factor associated with OSA. Chronic heart failure, that's well recognized. Increasingly in respiratory clinics, people with moderate or severe asthma, many of whom may be obese, may have OSA making symptoms worse. There's strong data from America, particularly about the links between polycystic ovary syndrome and OSA and insulin resistance. Lizzie Hill's work in Edinburgh highlighted how common it is to have OSA in people with Down syndrome, particularly because of their facial shape. They're predisposed to having snoring and OSA. Many people may not have heard of this non-arteritic anterior ischemic optic neuropathy, but your ophthalmologist will have. And this is where people present with sudden loss of vision in one eye due to decreased blood flow in the optic nerve. And it's typical on waking. And there's been quite strong research showing an association with OSA in this patient group. So it's on the list because there's robust data. You may get referrals from your eye clinic, and the concern is about the other eye, and the other eye being at risk and blindness being a risk. So that's why we need to think about OSA in this group of people. Hypothyroid and acromegaly are also there. So this is really about flagging to GPs and other hospital clinicians of people in whom to think about obstructive sleep apnea hypopnea syndrome, raising awareness with patient groups. And this, of course, is likely, we hope, to lead to increased referrals. The clinical guidelines group looked at how you assess people and recommended that the Epworth Sleepiness Scale is useful in a preliminary assessment of sleepiness. We have to be clear, it's sleepiness it assesses. It's not whether it's OSA, whether it's shift work, whether it's anything else, new baby, but it's sleepiness it assesses. One of the key things to say about the ESS, just jumping to the point below, is please don't use it to determine if referral is needed. Don't use a low score to rule out OSA. That is not reflective of the patients we see. ESS can be seen as a fairly crude scale. It's not diagnostic. And we heard that some GPs are unable, the CCGs are unable to refer people for sleep studies if they have a low ESS. So this line is particularly put in to change referral pathways for those people. So please refer if you're suspicious of OSA, whatever the ESS, because not all people have excessive sleepiness or may not have excessive sleepiness, which is manifest on the ESS. And it's got its flaws, but it is what is used. It's what's used by the DVLA. And therefore we thought it should still be in there, but people need to be aware of its weaknesses. The Stop Bang questionnaire was brought in by Francis Chung in Canada, and really extremely well established and well researched, brought in as a screening tool for OSA in pre-op populations, and now widely used, particularly in say the AF clinic, the pre-op clinic, maybe the resistant hypertension clinic. Take it, use it in those settings. And if people have a high risk of OSA, do refer them for sleep studies. What's worth noting is it's a risk of OSA, so it's not sleepiness particularly. It also focuses on the classic features of OSA, not those features of cognitive dysfunction or insomnia or sleep fragmentation. And so it may not flag all people, like particularly women or people with tiredness or insomnia. So it's a tool. Neither of these are the be all or end all. So moving on then, who should GPs refer to sleep services, and should any referrals be urgent? And I apologise here that I'm doing this talk and not one of our GP representatives, but unfortunately they're both busy today. So please accept me in their place. So we've really, this is just some guidelines to say what would be helpful in a referral letter. And this is, of course, not just from GPs, but from any of you who are in respiratory clinics, other clinics in the hospital, other healthcare provision areas where you're suspicious of OSA. Please refer them. It doesn't need to be a referral from a doctor, just whoever's seen the patient and asked the right questions and is thinking about OSA, please refer them in. It's certainly easier, and it's easier to prioritize people if we have the results of their stop bang and their Epworth sleepiness scores, some information about how sleepiness affects the person. Are they driving children to school every day? Are they a caregiver? Do they have a vigilance critical occupation? How is this affecting them? What are their comorbidities? Really important. Do they have any on the list before that mean we would want to prioritize them for sleep studies? Do they have an occupational risk? So again, vigilance critical work, which might include driving for a living or driving a long way to get to work. Certainly at the moment, lorry drivers delivering petrol, we'd put them to the top of the queue. We probably did anyway, to be fair. More on that in a moment. And if you have it, obviously not so much in general practice for blood gas values, but if you had it from a previous admission, or if you're referring from elsewhere in the hospital, this just helps prioritize, giving a taster for what will be coming later in the morning, thinking about, could they have obesity, hypoventilation syndrome? Could they have COPD, OSA overlap syndrome? So if you've got that to hand, brilliant. I've added on this slide, just to try and make it useful, things that will come later, but whatever you're referring them for, it's usually a single common pathway. If you think about these other conditions as well, those same factors, but also if there was a history of acute NIV having been required for acute respiratory failure, really essential to know that for prioritization. And if they have COPD, how bad is that and how frequently are they having exacerbations? I'd hasten to add, please don't delay trying to get all this information, just get them into the system. But obviously, if we're looking at prioritizing on our end, it's helpful to have this. So then coming to, for people who work in sleep services, who should you prioritize and how should you do that? Well, this is, I guess, obvious. And I suspect many services are doing this already. If we were in a lecture theatre, we'd have a show of hands, but put your hand up to yourself if you have a priority service, just to get the blood moving. So for a long time, many centres have been prioritising people with vocational driving job. That might be professional bus, train, lorry drivers, but also we recognise it's courier drivers, people with standard licences who need to drive for a living. We want them to come and be diagnosed. We don't want them to be driving unsafe. So you need to have some fast track pathway. More on that on the next slide. Anyone who has a job for which vigilance is critical for for safety, are they a forklift truck driver? Are they a petrol tank delivery person? Are they a surgeon? Are they a nursery nurse? All things where, you know, we should be prioritizing these people. Unstable cardiovascular disease, we felt this was sensible, that if people have poorly controlled arrhythmias, nocturnal angina, or treatment-resistant hypertension, they've got other risk factors. You want to get them diagnosed and started on treatment sooner rather than waiting for cardiovascular events to take place. pregnancy, clearly there's a mother and a baby you're trying to look after here. Your time limited for the pregnancy, you want to prioritize them if you can. The area of preoperative assessment for major surgery, it's hard to get strong, robust, randomized controlled trial data in this area, but certainly there is good cohort data saying people are probably at increased mortality, morbidity, longer post-operative complications if they have undiagnosed significant obstructive sleep apnea. So try and get them assessed. So at least anaesthetists know about it, and ideally onto CPAP before surgery. And again, that group with this sudden onset blindness in one eye, you want to prioritize them. They won't be a huge cohort, but you're trying to protect the other eye from blindness. If you're thinking again, just put this section here for completeness. The people who you want to prioritize with OSA plus conditions, so obesity or COPD, clearly, if they are already in respiratory failure with severe hypercapnia when awake, they should be near the front of the queue. If they're hypoxic with SATs less than 94% on air, if they have acute ventilatory failure, plus all the others. This is just a part of our discussion of today. Was we didn't want to just tell you what the guidelines say, anyone can read those, but to have really a discussion about how we might implement these changes. So this is really just to flag something we published in Newcastle and Stevenage a few years ago as to how you might prioritize people. And this is to emphasize, this is cost neutral. So if you aren't already doing this within your service, this might be of interest. We were able to establish a 4-week wait fast track sleep service. So from GP referral to being established and reviewed on CPAP, we proved we could do that within 4 weeks. And the way to do that, we made it for vocational drivers, but you could do it for any of those priority groups, is just to reallocate your existing appointments. So keep a few slots each week. It doesn't have to be that many. We found about between 2 and 4 that we left empty. We had them on a Thursday, so we left them empty until the Monday of that week. And with us, they were with Stevenage, they were a sleep nurse or a physiologist, and you leave them empty. So you've got a place you can put your vocational drivers or those priority groups. If you haven't used them by the Monday, there are plenty of people who will come at short notice and fill them. So you're not losing slots. You need a good administrator to just move people around slightly. Our nurses and physiologists saw them, assessed them, same night sleep study. They took kit home, saw them again the next day to download the kit and start CPAP if it was indicated, and then followed them up 1 to 2 weeks later. At the time we did this, it was in person, but of course that could be by telemonitoring, which is what we're doing now, and more remote approach. They had access to a troubleshooting helpline. And clearly you need to, your GPs, as NICE has recommended, to identify these drivers or other priority groups at referral so that you can effectively put them into these slots. But it's just a way we can perhaps discuss a little more of how to address it within, as we all know, a huge wait list for sleep services at the moment. And it seems like a nightmare as to how you're going to do something differently. But this is quite an effective and easy way to do that. Passing over to Anita now.
Thanks, Sophie. So having assessed patients, prioritise them, they come for diagnosis. And I think it's fair to say this was one of the most hotly debated areas for the Guideline Committee. And we know people feel strongly about what the best sleep studies are for diagnosis, because we had lots of feedback from colleagues, from other patient groups, from all the stakeholders involved. There are a number of considerations, really. Firstly, we did a close review of the literature, and we did a health economic analysis too. But one of the reasons why this is such a controversial area is that different sleep centres over time have developed their own best clinical practice. They have ways of doing things that work for them. And we wanted to try and move the area forward, but not be disruptive in doing so. The second important point is that really the technology for diagnosing sleep disordered breathing has evolved very considerably over the years. And therefore, studies that were done in the past are probably no longer relevant. And we had to sieve out those that we thought were relevant. And certainly the development of oximeters means that some of the early oximetry studies that were done are not relevant or not comparable to the oximeters and the kind of data that you can get in terms of sampling and accuracy today. So all of that was taken into account. Some comments on semantics, really, in that we've used the term respiratory polygraphy to indicate sleep studies where there are at least 4 channels, and that usually involves oximetry, respiratory effort monitoring, apnea, so respiratory flow, may include snoring, position, and there are other polygraphy equipment that looks at peripheral arterial tone, for example, the watch pat. So we looked at that sort of, that's our definition of respiratory polygraphy. So if we just see if I can move on, but I'll ask Sophie just to show the first batch of for diagnostic tests. Thank you. And a further point on NICE use of words, when they use the word offer, that means that this is the suggestion of choice, the option of choice. So offer means that it should be available for individuals. The terminology consider is also used, that this is an option that can be considered, but is not necessarily the first line, but depending on circumstances, it may be suitable. And that's really applicable to these first comments that we say first. So the first test of choice is respiratory polygraphy at home, and the health economic study that we did with the NICE health economists showed that on the grounds of taking into account the sensitivity and specificity of the equipment, taking into account the number of possible failed diagnoses in the first instance, that then the study had to be repeated, that taking a number of models which compared home respiratory polygraphy, in-hospital polygraphy, home oximetry, screening initial oximetry followed by polygraphy, that home respiratory polygraphy was the diagnostic method of choice in the first instance. But we've also said, as you can see in 1.3.2, lifted from the guideline, that if there are reasons that there is restrictive access to home respiratory polygraphy, then home oximetry can be considered. But it's important to take into account that it may not be as accurate as respiratory polygraphy in making a clear diagnosis. And for example, the use of oximetry in individuals who are already hypoxemic from chronic respiratory disease or heart failure may mean that the sensitivity and specificity is not as good. So first line treatment is home respiratory polygraphy, but if that is not possible, then home oximetry can be considered. If we then move on from that, so if the home oximetry result is negative or inconclusive and the individual has significant symptoms which are persisting, then we suggest that you move to respiratory polygraphy, so look at more channels, or depending on the symptom profile, one might want to move to polysonography. On the other hand, if an individual, their situation means that it's difficult to do home respiratory polygraphy, it's impractical because of where they are in terms of picking up the equipment, in terms of them being able to do the test, then we suggest that in-hospital respiratory polygraphy is considered for that group of individuals. And it might also be suitable for someone who is in hospital for a series of other tests. For example, they're having surgery or cardiac intervention of some kind, and so that can be incorporated within their hospital stay. But if the respiratory polygraphy results, whether they're at home or in hospital, or as I said, the oximetry results are inconclusive in an individual whose symptoms are significant, then the next line is polysomnography. So that's the more detailed monitoring. So in addition to the respiratory variables, we are looking at the sleep staging. So the different types of sleep, rapid eye movement sleep, non-rapid eye movement sleep, the number of arousals, and also one can look at other sorts of problems such as restless leg syndrome that can be disrupting sleep. And if you come on to the next one, please. So we use the sleep study in those circumstances to confirm the diagnosis. So whether the individual has obstructive sleep apnea, hypopnea syndrome or not, and then to determine the severity. And the typical way of doing that is mild, moderate, and severe. What we haven't included here is the additional measures one might use to diagnose obesity hyperventilation syndrome or the obstructive sleep apnea hypopnea syndrome, COPD overlap syndrome. And there we suggest that you consider using additional CO2 monitoring, especially, for example, if an individual with COPD is on long-term oxygen therapy, and for the obesity hyperventilation syndrome, it will help determine what treatments that you move on to, whether CPAP or non-invasive ventilation is most appropriate. But as I say in conclusion, and we'll be interested to hear your responses, this is what we have come up with as our tests of choice. But we do know that there are strong feelings, and we had those feelings represented on the guideline committee, in that there were some individuals included whose clinical practice involved first-line oximetry, and others who up to now has involved first-line respiratory polygraphy. Having said that, this is what we suggest is the practice from now on. And I'll finish at that point.
Thanks, Anita. So I'm going to invite my fellow panelists to all put their cameras on. And could the people at their homes or workplaces just move us all to gallery view so that you can see the whole panel, beautiful as everyone is. And then I'm going to invite Annabelle Nicol from Oxford, who's going to chair this discussion bit.
Thank you so much, Anita and Sophie, for an excellent introduction to today's session. And thank you so much to those of you who've written comments and asked questions. And I would just like to highlight some very interesting discussion points that have been brought to the fore. I'm going to start off with prioritisation. Thank you very much, Graham Wilson. You flagged to us it's really important that as clinicians, we don't entrench inequalities and prejudice against non-working, non-driving people. And I think we absolutely acknowledge for everyone who goes up the list, someone else goes down. Amongst our committee, we all had a gut reaction that in the end, gosh, we're prioritising everyone. And of course we can't. So hence needing to narrow it down and focus on a small proportion of people who are prioritised without keeping anyone waiting for a very long time. Thank you for your comments on when to suspect obstructive sleep apnea. Graham Wilson, thank you. You highlighted that we might not have thought of obstructive sleep apnea first off, looking at the glamorous Carrie Fisher. Marcel, Head of Physiology at Lincoln, you highlighted that you're seeing a lot of referrals for patients with atrial fibrillation. I think this is particularly important for those in whom it's paroxysmal, who might be about to have cardioversion. In my practice, I notice a flurry in a particular diagnostic group. And I think, well, either there's been a paper published or someone's given a talk within the department. Peter Venn, thank you. You highlighted that Chris Hanning demonstrated an increased prevalence of obstructive sleep apnea in pregnant women who have preeclampsia. That appeared in the third trimester. You asked, is there work on screening for sleep apnea in pregnancy? I do know that there's a large population study that has been carried out in Australia, and that is going to reveal the relationship between snoring and complications of pregnancy. So when that's in press, that will be very interesting. Are there any more questions that are coming up on? Oh yes, there's quite a few coming in. Any more comments from the panelists so far?
Yeah, I was going to say, I can see questions coming through on the CO2 monitoring and whether it adds anything. I think this is a fair question. It's certainly where we're talking about that is with respect to obesity hyperventilation syndrome and the overlap syndrome. And I think Maxine was saying, does it add anything if you, in obesity hyperventilation, you have a raised CO2 during the day? I think what we've said is consider. So we haven't said offer. I certainly think there's probably more of a role in individuals with the overlap syndrome. The comment about, so I think there was a morning arterial blood gas and a random daytime arterial blood gas. Others may have different views. I have always been suspicious about morning arterial blood gases. If it's high, then it's high, and the person, it depends whether, and they're likely to be awake when you've done a blood gas, so they're in daytime respiratory failure. I think random values during the day are of some help, but they won't necessarily tell you how to optimally control your ventilatory settings at night. You might argue, well, I've corrected their CO2 level during the day, so I must have the best settings at night. If you do that, you may find you have not got entirely optimal settings at night, but to cut a long answer short, we have said consider using it, and we haven't said that CO2 monitoring overnight has to be offered in obesity hyperventilation and overlap.
So Anita, your point is really well made. In Oxford, we're a centre that doesn't do overnight transcutaneous CO2, and as a substitute, we pay particular attention to base excess and bicarbonate on the daytime gas, and may sometimes do overnight oximetry. We acknowledge we'll be missing point spikes in CO2 at night.
There's a question from Stephanie Mansell asking whether we included peripheral arterial tonometry. It's in there. It's in the chat rather than the questions. Actually, I think people are answering on both. And we did include peripheral arterial tonometry studies in our analysis. So as long as they had sufficient channels, they were deemed to be appropriate, and we included them in our analysis. So they're considered to be included with the respiratory polygraphy recommendation.
And Ian, maybe it's worth just highlighting that for respiratory polygraphy, that meant at least 4 channels, but we didn't define exactly what the channels should be.
Anita, there's one from Chris Turnbull. Was night-to-night variability of OSA considered when determining whether one night of respiratory polygraphy is sufficient?
It's a very good question, because there's quite a few new papers coming through on this topic. Yes, we did consider it as a panel. We didn't look at vast numbers of different studies in terms of looking at whether you compare 1 night, 2 night, 3 night. So in essence, our comments refer to a single night study. But as clinicians, I think everyone would recognize that if the person reports that they had a terrible night, it was an atypical night, some of the equipment fell off, that you would repeat the study on common sense grounds.
Liz Spillen-End has said, if polysomnography is not available locally and sleep studies are negative or very mild, would you advocate a trial of AutoSet CPAP? So in our practice, even if a sleep study was very mild, I think or another situation, if there's a high symptom burden and you don't know if it's sleep apnea as the primary cause of that, I think it's very reasonable to have a trial of treatment. It's like diagnosis by trial of treatment. would we give CPAP if the study was entirely negative, but the history is convincing? I wouldn't personally, because I think then you're saying that the diagnosis itself isn't important.
Yeah, to add to that, I agree it's a reasonable thing to do. Where you run into problems are that the individual then is not tolerating the CPAP well, or doesn't feel any different on the CPAP. And there, I think you really do have to find a way of getting polysonography done. So if they feel better, you know, you're winning. But if they don't, then you really do need to do something else and get a clear diagnosis.
There's a final question then, and then I think we might have a break for coffee. Mariam Mohammed, to what extent should risk groups prioritised for assessments also be prioritised for treatments, whether symptomatic or otherwise? i.e. results show mild OSA, not symptomatic, however, patient has risk factors. And if treatment is provided, which level of therapy, CPAP or MAD? Okay, so we're going to have a session in session 3 about who MADs are suitable for. Annabelle, do you want to take that one?
I've had a patient with ophthalmic problems, but their obstructive sleep apnea was extremely mild and they weren't sleepy. And so I felt that the decision making about CPAP could be through patient choice rather than being of high urgency.
I think I would feel the same. I think if you've got a you know, unstable arrhythmia and severe OSA, that's the group to prioritize. I think if it's milder, they're judgment calls, aren't they? But I don't think everyone can be prioritized for everything. And then final one, and then I think we'll break, sorry. What diagnosis would you then give, Annabelle or Anita, a patient if trialing APAP, if symptomatology improves? So this was a person, you didn't have a diagnostic sleep study, but symptoms made you try CPAP or APAP and they've got better. I think we'd call that OSA, wouldn't we?
So yes, I think in my book, we call it diagnosis by trial of treatment.
Yeah, agreed.
Fantastic. Thank you very much. So Sophie, I think we're in a pretty good position for timekeeping. Well done and thank you. So a 5-minute break.
5 minutes and we'll restart at 10:28 with the next session.